Recording in progress.
Good afternoon. So, as they want contact classes, we can start with the basic classes. But what I feel is you already having videos in your module. Whichever is not there and which is left over, we can discuss here. So we can have a interactive session rather than one-side discussion. Okay, today I'm going to start on renal replacement therapy in intensive care unit. Basically, basic principles involved here. Okay, so if you see the acute kidney injury prevalence is as 22% in one of the studies, meta-analysis of 3.5 million patients, and it is up to 57% in the ICU. Means many patients in ICU require dialysis or renal replacement therapy. The incidence of dialysis requiring acute kidney injury is 10% increasing yearly. So the need of dialysis and need of renal replacement therapy is increasing. Renal replacement therapy are commonly used in critical patients to achieve solute clearance, maintain acid-base status, and remove fluid excess. This is the most common indication we use in ICU, either because of the renal failure, there is a toxins accumulation like blood urea, creatinine, or maybe poisoning patients, or to maintain the acid-base balance and to remove more and more fluids accumulate in the body. So this is the most common, indication in the ICU. So coming to the most important part is general principles in case of renal replacement therapy. So general principle guiding the removal of water and solute for almost any type of extracorporeal RRT. It may be, if you see the previous modalities or present modalities, whatever it may be, the principles will be the same. Okay. So one is convection, diffusion, ultrafiltration, and adsorption. These are four basic principles are involved in the renal replacement therapy. So if you see here, this is a you can say hemofilter or hemodialyzer, or it consists of semi-permeable membrane. Blood is traversing from one direction to other directions, and dialysate is traversing in opposite direction. So that's how usually the circuit works. In this dialyzer or hemofilter, there may be ultrafiltration principle may be working, or maybe diffusion principle may be working, or maybe adsorption. Adsorption is not routinely used. Most commonly used either diffusion in case of hemodialysis or convection in case of hemofiltration. That I'm going to discuss one by one. If you see here, diffusion means it is a hemodialyzer or hemofilter. Here, the movement of solute across the semi-permeable membrane. If you see here, it's think like a semi-permeable membrane here. There is a molecules are traveling from one to other side. Okay, the movement of the molecules depends on the concentration gradient. This direction intensity of the movement are driven by the concentration gradient. If you see here, red ones are middle molecular weight solutes and small ones are low molecular weight solutes. Here, low molecular weight solutes are easily permeable, okay, from across the semi-permeable membrane. So the circulating blood and dialysate, as I told, the blood is flowing in one direction, but dialysis flowing in other direction. This is to improve the efficacy of the permeability, because once it moves in opposite direction, so what happens? It will not attain the equilibrium. This dialysate will be going through outflow here. So again, there is a negative concentration will be maintained in the other side of the membrane. So the circulating blood here and dialysate flow is here, or direction each side of the semi-permeable membrane, the counter current flow, it is called as counter current flow, maximize the constant gradient and potentiates solute clearance. If you see here, smaller solutes less than 100 daltons crosses the membrane faster than the larger molecule. This is the most commonly happens in diffusion. Diffusion is the commonly used in hemodialysis. Please remember, in hemodialysis. Just here I'm talking only about the basic principles involved in the hemodialysis, hemodiafiltration, ultrafiltration, those techniques. So the basics of acute renal failure, need of dialysis, we'll discuss in the some other time. Also, there's, I think there is a modules are available with respect to that. Coming to the ultrafiltration, the movement of fluid across semi-permeable here, ultrafiltration, it is a fluid movement from higher to lower pressure to generate ultrafiltrate. This is a movement of fluid from higher pressure to lower pressure. That's all. In renal replacement therapy, the net ultrafiltration rate means the total amount is fluid removed to obtain net fluid balance, means total amount is out. That can be described as, in case of continuous therapy, we call it as continuous renal replacement therapy. In that case, we will describe like a 40 ml per hour, 50 ml per hour. That is the dose we can say. We can tell it as dose of the dialysis. Or in case of intermittent hemodialysis, what we do routinely in most of the ICUs, it is like a 2 liters, 1 liter, 3 liters. That is the ultrafiltration. So it's nothing but fluid removal, okay, across semi-permeable membrane. That is the ultrafiltration. The another most commonly used principle is convection. Convection describes the process by which solutes are transported across semi-permeable membrane. Solutes here in ultrafiltration fluid is removed. Here solutes are removed, transport across semi-permeable membrane. You can see here together with the solvent. Along with this solvent, this is what is called as solvent drag. Solvent drag means along with this fluid or solvent, solutes are moved from one part to other part of the semi-permeable membrane. This is according to the transmembrane pressure gradient. It depends on the transmembrane pressure gradient. So convection can remove not only smaller molecules, here with the higher molecule also, larger, middle-sized molecules also removed, which diffusion cannot be able to do it. Means whatever hemodialysis is not able to do, here filtration or convection can be doing that process. That you should know which molecule to be removed during dialysis. That depends on, we should know whether to use dialysis or filtration. Another technique most common, most not commonly, which is now it is like a interesting to nowadays used in sepsis and all. It is a newer technology like a adsorption, which even the principle is old, but technologies are adopted more and more towards adsorption. Adsorption here, it is adherence of the molecule to the surface of the polymer, a charged membrane exposed to blood. Here, polymer or membrane will be progressively saturated by those molecules, leading to progress reducing absorption capacity for longer treatment. Means here there is some adsorption area is there where these molecules goes and adhere to that. Okay, that's all. So it is used in case of newer technology. What I say is in sepsis, people want trying for removal of the cytokines. Cytokines means there may be pro-inflammatory mediators will be there or anti-inflammatory mediators will be there. So they are planning to remove more and more pro-inflammatory mediator so that inflammation can be reduced in sepsis. That concept they are trying in trying with the adsorption technique, but in routinely we are not using it. We are using only this diffusion and convection and ultrafiltration. These are three major principles are used in the dialysis that you should know whenever you are talking about dialysis. So if you look at the circuit here, circuit is, I think most of you have seen the dialysis in your ICU daily, there people are doing it. So it is a pump driven system. Pump driven means there is a pump will be there, okay, that have diverted the blood from the from the catheter where you are putting. Most of the time catheter we are putting intrajugular catheter. The pump driven circuit with the vascular access to established by insertion of large double lumen venous catheter. This large double venous catheter usually keep in the IJV. You can even use femoral catheter. Very rarely people use subclavian. Most commonly used IJV. That you should know. So here what is happening? Here blood is taken out from the through intrajugular vein, that is a blood pump driven, entering into the dialyzer or filter, we can say. This is a hemodialyzer or hemofilter. Okay, here what is happening, as I told, it may be a diffusion technology is working, the principle may be working, or it may be convection or ultrafiltration. That is what happening here. Later, blood is again going back to the, you know, venous intrajugular vein. This hemodialyzer, hemofilter, used as an artificial kidney, which are generally composed of semi-permeable membrane. As I told, it usually cellulose or synthetic polymer membranes fabricated as a hollow fiber through which blood is perfused. Here it is, cellulose or synthetic polymer membranes fabricated as hollow fibers, allowing as large as exchange surface area of 1 to 2.5 square meter, means very big square surface area is here, so that diffusion or convection or ultrafiltration can take place. That you should know. Coming to the vascular access, before initiating any dialysis, you think of vascular access, most commonly used, as I told, intrajugular vein. Second choice will be femoral vein. Usually why we are avoiding femoral vein is, there is more risk of infection. So you want to keep the catheter longer period. So intrajugular vein is more comfortable. So in case of right and left, right is the most common use, left is second option. Last choice is subclavian vein. Why we are not using subclavian vein in earlier means, it is the because of the there is a risk of complication during insertion, like a pneumothorax, arrhythmias, and also there is a risk that subsequent venous stenosis can occur, in the occlusion can occur, where we cannot do AV fistula. Means if the patient become dialysis dependent, later we need AV arteriovenous fistula, where it is a permanent option that we cannot keep dialysis catheter for longer period. We can keep for 15 days, 1 month, then we have to remove it. Otherwise, it can cause infection. So next we have to go for AV fistula if the patient becoming dialysis requiring person. In that case, if you already use subclavian, there may be possible stenosis, then we cannot use AV fistula. So most commonly 13 or 14 French wide bore catheter used. You should know this. And this is the formula. Whenever you have to use which catheter to be used, this is the flow. This flow is depends on the, radius. It means radius to the power of 4. Means more the wider the diameter, more flow will be there. So always we have to use wide bore cannulas. So again, this same principle used in the resuscitation. We have to use wide bore cannula rather than narrow cannulas. Like if you want to use, if I ask you which is the resuscitation line, like a 18 gauge or 16 gauge cannula or center line, we always think of 18 or 16 gauge cannulas are better resuscitation peripheral lines rather than central line because of the wide bore. And if you see here length, the more the length is there, the flow will be reduced. So you have to use short and stout and wide bore cannulas to be used for registration. Same principle used here. We have to use short and wide bore cannulas to be used while putting vascular access. Coming back to the principles here. So with that, we have option of hemodialysis, hemodiafiltration, hemofiltrations. So many we can permute and combine. We can come out with the several options. The first option you can see here, hemodialysis. Here is the diffusive process. I told diffusive process, as I told, is a constant dependent, where blood is passed over semipermeable membrane, which separate it from the electrolyte solution. This electrolyte solution flow in the opposite direction, as I mentioned here. This electrolyte solution, we call it as dialysate. Dialysate is a solution which, if you see here, it is a solution constitute of same electrolytes and components as of blood. But if you see here, in the electrolyte or dialysis solution, which contains essential solute present in plasma water, and waste solutes are removed by their movement down a concentration gradient from plasma water into the electrolyte compartment, which is called as dialysate. Example I can show you here. Here sodium, if it is both side is normal, so sodium is not moving out. Potassium is here, it is high, it is low, so potassium is moving out. Means in case of patient coming with acute renal failure, hyperkalemia, if this dial is having low concentration gradient, so potassium is come out of from blood. Chloride is same. If you see here bicarbonate, you can see blood urea here 30, urea is 0. So blood urea is come out and enter into the dialysate. Creatinine is comes out like that. Magnesium, if it is high, it comes out like that. So what happens here? This dialysate constitutes now comes more of blood urea, potassium, and all that is entering into the effluent and goes out. So this is how that electrolyte solution works. This electrolyte solution constitutes also changes as per the which company you are using. Again, important hemodialysis per se. Here, the diffusion, as I told, this diffusion depends on diffusion coefficient. We call it is depends on or inversely related to the molecular weight of the molecule. Molecular weight means higher the molecule, it doesn't goes out like a albumin, beta 2 microglobulin. Urea and beta 12 moves out easily. It also depends on the which type of membrane you are using. It may be high flex membrane or low flex membrane. High flex membrane most commonly used nowadays is non-cellulose. Modern as are non-cellulose membranes. Those are called polyacrylonitrile hemofilters or PAN. Polyacrylonitrile hemofilter or PAN membranes are used, which is considered high risk flex membranes. It also depends on the rate of blood flow, as we mentioned in the earlier, and membrane properties, high versus low, rate of flow of dialysate, and membrane surface area. It also depends on the four factors in case of diffusion. Coming to the next principle is convective process, which is used in hemofiltration. Convective process in which hydrostatic pressure gradient, as I mentioned, water is moving from the higher pressure to lower pressure, used in the filter plasma water and solute across the membrane. This fluid is then discarded. You can see here, this effluent consists of ultrafiltrate. Is a during hemofiltration, no dialysate. You can see here, no dialysate is perfused here. There is no dialysate here. It's only a high pressure to low pressure fluid is removing. Along with the fluid, solutes are removed. Okay, there is no dialysate here. So during hemofiltration, no dialysate is perfused, and the effluent consists only with the ultrafiltrate. This we call it as effluent. Effluent consists of only ultrafiltration. So in convective process, given the high rate of ultrafiltration, means required to achieve adequate solute clearance. As I mentioned, to remove the solutes, we need a large fluid is required, like a crystalloid solution with physiological concentration of electrolytes. These are to be reinfused to prevent intravascular volume depletions. Because a lot of volume is going out here, we have to replace the fluid in case of hemofiltration. This is called replacement fluid or replacement fluids. Yes, these replacement fluids can be used before the dilution, called pre-dilution replacement fluids or post-dilution replacement fluids. What I mean to say is, in convective process used in hemofiltration, large amount of fluid comes out of the composed through effluent that should be replaced by using crystalloid solution with physiological concentration. It can be used pre-dilution, pre-filter, or post-filter. The replacement fluid may be infused after hemofilter. It is called post-dilution, which is associated with the hemoconcentration because of the hemoconcentration of blood within the hemofilter. Means here, more concentrated blood is here because you are diluting fluid here actually. When the moment the more and more concentrated blood is here, that increases the risk of clotting. Here, clotting formation happens in the hemodialyzer, hemofilter. So this we should keep in mind. If you use the pre-dilution, before the hemofilter, if you use pre-dilution replacement fluid, then we can mitigate the degree of hemoconcentration. There is no possibility of hemoconcentration and clotting risk will be removed. But what happened? This dilutes the concentration blood entering into the hemofilter, means it becomes diluted and we cannot able to remove the more and more toxins like a blood urea, creatinine. Lesser will be removed, means efficacy will be reduced. So this you should know, whether we are giving replacement fluids before the filter or after the filter. After the filter risk is there is risk of clot formation in the cartridge, or before means there is a risk of reducing efficiency because more and more blood is diluted. So for given PMP, means this is called transmembrane pressure, higher membrane permeability and more fluid is filtered per unit time. This depends on the synthetic membrane or cellulose membrane. As I mentioned, now we are using more and more non-cellulose membranes. Rate of it also depends on the rate blood flow, hydrostatic pressure gradient, hydraulic conductance means permeability of the membrane. That depends on the type of membrane we are using and surface area of the membrane. So coming to the hemodiafiltration means there is both dialysis also there as well as filtration is also there. Dia means dialysis, filtration means both ultrafiltration. So in this case, both, if you see here, name itself tells dialysis means diffusive principle is used. Filtration means convective used during the transport. So both combine diffusion and convective solute transport with the perfusion of dialysate. Here we are using the dialysate here because it is a dialysis also there. Diffusion technology is there through hemofilter combined with the generation of ultrafiltrate. Ultrafilter means you have to replace with a lot of fluids here. Here replacement is done post filter. It is a post dilution filter. So it is all reinfusion of fluids or replacement fluids also called. So here hemodiafiltration, both dialysis and filtration will be there. So with this technology, now they have put a names, for with respect to renal replacement therapy. Like if you depends on timing also. If it is used intermittently, we call it as intermittent hemodialysis. This is most commonly used in day-to-day practice in all the ICUs. Intermittent hemodialysis is a shorter duration, like 3 hours, 4 hours, and a more effective dose is used here in a shorter duration. This intermittent hemodialysis risk of, because large amount of fluid is removed and solute clearance is happening in a shorter duration, there is a risk of hypotension. If to avoid the risk of hypotension, people are using longer duration of hemodialysis. That is called prolonged intermittent renal replacement therapy, PIRRT, or also called SLED. SLED nothing but slow efficiency dialysis. So most commonly used is IHD. If there is risk of hypotension is there and you don't want to remove fluid for a shorter duration, you want to increase the duration because of risk of hypotension, then we can go for prolonged intermittent RRT or SLED. Some institute have CRRT, that is continuous renal replacement therapy for 24 hours. This is called continuous CRRT, continuous renal replacement therapy. The advantage here is more hemodynamic stability. BP will not be because slowly the convection or ultrafiltration happening very slowly here. So there is no risk of fluid shift or hypotension. So the disadvantage CRRT is patient is not mobilized. Here intermittent hemodialysis patient can be mobilized once the procedure is over, but here it is more of bedridden. So this is a risky area. So the type of extracorporeal circuit is described is pumped veno-venous. So we call it as veno-venous. Always you can use like which technology are you using? Veno-venous with the method of blood purification. If you are using only filtration, it is called veno-venous hemofiltration. If you are using both dialysis and filtration, filtration means removal of fluid. Dialysis means removal of solutes. If you are doing removal of fluid, solutes, and both together, we call it as hemodiafiltration, which becomes veno-venous hemodiafiltration or veno-venous hemodialysis. If it is intermittent, we can use intermittent hemodialysis. So many nomenclature has been given here. We can use here the word continuous veno-venous hemodiafiltration. Means continuous means it is a longer duration, CRRT, like a 24 hours. Veno-venous most commonly used veno-venous only. Hemodialysis filtration, both hemofiltration means ultrafiltration. There is no much ultrafiltration. Fluid removal is not happening here. Here both fluid removal and solute removal is there. Here continuous veno. Hello,
Hello.
can you hear me?
Yes, sir. Now it's clear. It was not audible.
What happened?
So it was getting stuck.
Now it's clear, right? Okay.
Yeah, now it's fine.
So we are using the different terminologies, like as I told, continuous venous hemofiltration. Continuous venous hemofiltration means, here it is a continuous, means CRRT, venous commonly used. Hemofiltration, only here water is, fluid is removed, not the solutes. It is a hemodiafiltration, means hemodiafiltration means it's not continuous. It may be intermediate hemodialysis, IHD, or intermediate hemodiafiltration also. So that's how we can use the terminologies, depends on the whether we are removing solutes or fluid. With that, we can look into here. It is a continuous hemofiltration. Here, double lumen is passed through the large bore catheter, is placed to the center vein, that is intrajugular vein. Pump drive one flow is allowing perfusion of the fluid through the cartridge containing semi-permeable membrane, usually fabricated as hollow fibers, as I mentioned here. During hemofiltration, fluid ultrafiltrate containing high concentration of urea and solutes are driven across the membrane by hydrostatic pressure gradient, because it is a hemofiltration, and drained through the effluent port. This is effluent port. This is going out. So volume of re-injection of then again blood is entering to the intrajugular vein here. So replacement fluid is important. Volume of re-injection needs to be slightly lower than the ultrafiltrate to maintain lesser negative fluid balance. This depends on the how much fluid is going out. It depends on that we can replace fluids. This is a classical circuit used in the continuous hemofiltration. So if you have to know the filtration fraction also, filtration fraction is a factor which influences the filter viability. It is, you can look at the ultrafiltration rate or plasma flow, this filtration fraction is equal to ultrafiltration rate divided by plasma flow. This is the fraction you should know. Here, plasma flow can be calculated with the 1 minus hematocrit into blood flow rate, becomes plasma flow rate. So why it is important in CRRT, this filtration fraction should be less than 25%, because should not be less than, above less than 25% increase the risk of clot. More and more filtration fraction is there is a clot risk will be there because of hemoconcentration. So this we should know. Because of this, we always keep the filtration fraction lesser. Okay, imagine here blood pump speed is 250 ml per minute, hematocrit is 0.3, 1 minus 0.3 into 250 becomes 175 ml per minute will be the plasma flow rate. If you ultraflow rate, if you maintain around 45, then 45 divided by plasma flow is 175. That is the ratio we'll take. In order to maintain filtration fraction less than 25%, ultrafiltration rate should be no higher than 45. It should be less than 45. This you should know. We cannot increase the ultrafiltration significantly, because if we more and more increase the ultrafiltration, the risk will be the clotting fraction will be there. So if this is the schematic continuous hemofiltration driven by venous circuits. We can see here blood is coming through in this direction. Okay, transmembrane pressure is reduced because the equilibrium is attained here. Okay, substitution fluid is here, post filter it is there. It is and you can see transmembrane pressure, blood flow maintained around 150 to 250 ml per minute. This blood flow is 150 to 250 ml per minute. Filtration rate is 25 to 50 ml per minute. What is happening here? Only convection is happening because hemofiltration, diffusion is not there. Minimal adsorption is also happening. This is how it happens here. Continuous hemodialysis, here what is happening, same circuit here. Dialysate here perfused in opposite direction across the external surface of the hollow fiber membrane to allow diffusion solutes with ultrafiltration provided extent needed to achieve the discharge fluid. Means here effluent consists of dialysis, the electrolyte solution also. During renal replacement therapy, regional anticoagulation, I'll discuss again anticoagulation. Anticoagulation is must because clot formation should not happen here in the circuits. Can be here, regional anticoagulation can be done, or systemic anticoagulation can be done, or no anticoagulation can be done. These are three types are there. Here they are used citrate. It is an anticoagulation, may be provided through the before the cartridge here, and infusion of calcium should be done after the cartridge, because citrate use more and more calcium. Whenever you use citrate infusion, they are mentioning calcium infusion post filter to be used. That we discussed again. So it is a hemodialysis. The only dialysis happening here. So if you see here, 80 to 150 ml per hour dialysis blood flow is there. Dialysis rate is 10 to 35 ml per minute. Here convection is very less. More and more diffusion is happening here. This is what continuous venous hemodialysis works. Continuous hemodiafiltration, as I mentioned, both ultrafiltration as well as dialysis happening here. So higher the ultrafiltration are combined with the dialysis flow. So there is a dialysis flow is there, and we have to replacement fluid should be done because there is a ultrafiltration is happening. So effluent flow here consists of both diastylate and ultrafiltrate. So here again, anticoagulation can be done with the either systemic anticoagulation or regional anticoagulation should be done in doing continuous therapy. Here, if you see continuous venous hemodiafiltration. Continuous venous hemodiafiltration means both dialysis is happening and ultrafiltration, fluid removal is also happening here. Blood flow is 100 to 250 ml per minute. Dialysis flow is 10 to 35 ml per minute. Flow, that is filtration rate. This filtration rate is 10 to 50 ml per minute. QD plus QF, that is the effluent rate. Effluent rate consists of both filtration as well as diary flow, that is 25 to 85 ml per minute. Here both convection is happening, diffusion happening. So both added together it is happening 20 to 85 ml per minute. Both QD plus QF become the effluent rate. This is how that you can use different combination in case of continuous replacement therapy. In regular hemodialysis, which is intermittent hemodialysis, here what is happening, same circuit here. Here larger volume is removed and shorter duration. So here higher blood flow and dialysis flow will be there. Dialysis flow will be very high and blood flow will be very high. It differs from the continuous form of by using higher blood flow like a 200 to 400 ml per minute. Urine can increase more, and dialysis flow will be 500 to 800 ml per minute. Very high flow rate will be there because it used in a shorter duration. Here same thing here. Blood flow is 200 to 400. Dialysis flow is 500 to 800. Both diffusion. Only diffusion is happening here, no convection. So some hybrid technologies, as I mentioned, because intermittent hemodialysis can cause more and more hypotension. So people we are using more of hybrid technology. Hybrid technology in the sense increase the duration. Okay, better hemodynamic tolerability, slow efficiency, sustained. SLED means sustained low efficiency daily dialysis. Sustained low efficiency daily dialysis. Or you can use sustained low efficiency daily diafiltration, both ultrafiltration dialysis happening. Extended daily dialysis means duration is more, DDD. So we can use SLED-F or EDD. It is a hybrid technology to have a better hemodynamic stability. It is again same thing is discussion here, intermittent hemodialysis, where dialysis is happening. In hemodialysis filtration, both convection and diffusion is taking place. Regular IHD machine is useful. 3 to 4 hours. Commonly used is 3 to 4 hours. Okay, 3 to 4 hours. And 3 to 4 days per week. One means alternate days we are using here. 3 to 4 days per week. That is the commonly used. 350 to 400 ml per minute. That is a blood flow range. Most commonly used blood flow range 350 to 400. Please try to see these things in your ICUs when you are when patient is going for dialysis. Dialysis QD is 500 to 800. Very high flow rate is there because of it is intermittent hemodialysis, shorter duration. Ultrafiltration go for 1 liter, 2 liters, up to 5 liters they are mentioning here. Prolonged intermittent renal replacement therapy may be SLED, only diffusion is taking place, or SLED-F, there is both convection diffusion is there. Same IHD machine can be used 6 to 12 hours rather than 3 hours. It is 6 to 12 hours. 3 to 7 days per week can be done. Here flow rate is blood flow rate is 150 to 250. Dialysis flow rate is 100 to 300 reduced rate. Ultrafiltration can be done according to need basis. So next one is continuous renal therapy. Only convection in case of hemofiltration. Both only dialysis in case of dialysis, diffusion in case of dialysis. In ultrafiltration and diffusion, both diffusion and convection is taking place in case of hemodiafiltration. So it is a CRT machine is required. It is a bit costlier also. Duration is continuous, 24 hours. Frequency is continuous. Blood flow is 100, usually 100 ml per minute or 200 ml per minute. diafiltration is dialysis rate is 25 to 30, and ultrafiltration usually 0 to 200, like a 45 to 35, 35 to 25 will be there. So most common absolute indication, if you see here, most commonly used dialysis where they use most commonly used dialysis in case of pulmonary edema, hypervolemia, hyperkalemia, severe acidemia. These are the commonly used indications, means life-threatening indications. So, or uremic complications like a uremic pericarditis, uremic encephalopathy, or dialysable. Most dialysis toxins are salicylate, methanol, ethylene glycol. Most commonly dialysable toxins, salicylate, methanol, and ethylene glycol. So what I'm taking is this is the absolute indication for RRT. And further discussion you can go through in your modules also, commonly used indications. Here what I'm telling is, instead of this absolute indication, people are used when there is a no absolute indications, but we can do early dialysis when blood urea is rising up. So that is called early initiation or timing of RRT initiation. So many trials are there where they use less than 8 hours of stage 2 renal replacement therapy. Stage 2 means you should know the grading of Akin grading, or also you should know, rifle criteria to know the staging and all. That can be discussed later in other class, or if it is available in the module. So these are the commonly studied when to do dialysis when there is no absolute indications, either less than 8 hours or less than 6 hours of stage 2 or stage 3 or less than 12 hours of failure. So only first study Elan has found some benefit, but rest of the studies like recent trials are START AKI and Akiki 2 trials found that almost 4,000 patients has been concluded that early not much helpful. Early not much helpful. Therefore, conservative approach consists of watchful waiting unless life-threatening indication emerges seems to be recommended. Means if there is absolute indication, like is there like a patient going with acute renal failure, fluid overload, acute renal failure with hyperkalemia, acute renal failure with uremic pericarditis, uremic myocarditis, encephalitis, any absolute indication, yes, you can go in for dialysis. There is nothing workouts like early and late. If there is no absolute indications, at what level of blood urea, at what level of serum creatinine, or at what level of stage 1, 2, 3, 4, when to do dialysis, that is the indication. Means you go with conservative, don't unless there is a life-threatening indication is there. Careful, watchful waiting. If there is a trend is increasing, patient is not improving, patient is oliguric, anuric, potassium is increasing, then you can go for dialysis. So again, there is a many studies with respect to, either we can go for continuous renal replacement therapy or intermittent renal replacement therapy, hemodialysis. So intermittent is disadvantage, hypotension. Advantage, patient will be mobilized early. Continuous here there is a disadvantage, it cannot be mobilized, but there is no problem with the BP. Patient can be BP can manage very nicely here. There is no problem with the BP. Since neither the modality intermittent or continuous nor clearance by the convection or diffusion has shown the superiority. So none of the studies have shown that one is intermittent is better than continuous with respect to mortality. Both are same with respect to mortality, and even with convection diffusion, both are same. Means if the patient is hemodynamic unstable, yes, you can option of CRRT is there, go for CRRT. If the patient is hemodynamically stable, you can go for intermittent hemodialysis. If the patient is hemodynamic unstable, you don't have CRRT, then option is SLED or SLED-F can be done. Means intermittent hemodialysis, longer duration can be done. So that's how we can go with the type of dialysis. So dosing of dialysis, dosing of assessment and guidelines recommend using clearance of urea. Depends on the clearance of urea or the treatment sessions. So guidance recommend more go with the clearance of urea rather than treatment options. So there is a two options. Clearance of urea can be identified with the urea reduction ratio. URR means 100 into 1 minus creatinine end of the dialysis, and CO means creatinine pre-dialysis. The formula is there. This formula, it tells the urea reduction ratio. Another formula is KT bar V urea. This is commonly used. K means clearance, T means time, V means distribution of volume, estimated as a body water volume. So for example, if a blood flow is 300 ml per minute, okay, and QB into 180 timing, that becomes 54 liters. 70 kg ultrafiltration rate will be for the 60% body weight become 42 liters. Estimated non-adjusted KTP by urea become 54 by 42, 1.3. So this is how they, volume, sorry, not, it is a volume of distribution. 70 kg volume of distribution is, water is 0.6. 70 kg into 0.6 becomes 60% body weight, it will be the body water, it becomes 42 liters. So KT bar V will be 1.3. This is how they identify the dose. So the dose for the intermittent hemodialysis, they use either urea reduction ratio or KT by V. For the CRRT, the dose used with respect to total effluent rate. The total delivered effluent rate normalized to actual weight is used as a quantified clearance. So the total effluent rate, as I mentioned earlier, the total, the re-injection flow rate, pre minus post filter, is CVH or CVHDF, and the rate of dialysis flow plus ultrafiltration. Here, if you see here, total effluent rate will be the re-injection fluid will be around 1400 ml, dialysis flow rate will be 1400 ml, ultrafiltration will be it is around 50 ml, becomes 1400 plus 1400 plus 50 becomes 2850 ml per hour. Net ultrafiltration flow rate per kg per hour will be 33 ml. So this is how they identify CRRT dose per kg. So CRRT dose per kg, it will be identified with the like a effluent rate per ml per kg per hour. For the dialysis, they use KT by V dosing. You should be able to understand the dosing with respect to hemodialysis. So current evidence does not support using intensive therapy for all patients. All studies mentioned goes with the conservative therapy. For intermittent modalities, dose will be prescribed IHD at least 3 times a week. Alternate days most commonly used to maintain volume and metabolic balance as long as there is no sense of underdosing. Or you can use KT by V urea less than 1.2 per session, or URR you can use 67%. For continuous therapies, a pre-described effluent volume will be 25 to 30 ml per kg per hour is adequate. So for CRRT, the dosing will be 25 to 30 ml per kg per hour in most scenarios. Even though we give 25 to 30 ml per kg per hour, the delivered dose will be lesser than that most of the time. It will be 20 to 25 ml per kg per hour. So for CRRT dosing is 25 to 30 ml per kg per hour. For hemodialysis dosing will be KT by bar V urea will be less than 1.2, or urea reduction ratio will be less than 67%, or you can use IHD at least 3 times a week. That is the intermediate hemodialysis dosing part. So this is the 3 dosing part you should know. Anticoagulation, this is a few more slides. As I mentioned, filtration fraction above 20% is also increasing bleeding. So we have to use, in case of anticoagulation, sometimes in ICU we cannot use anticoagulation because of the thrombocytopenia, INR will be high, coagulopathy will be there, and patient need dialysis. Then we can go for no anticoagulation or only small dose, single dose of unfractionated heparin. So we can, this is one of the option in ICU, no anticoagulation, but careful with respect to blood clotting. Blood clotting, as I mentioned, more than 20% filtration fraction will be clotting increases. So in this, reducing filtration fraction less than 20%, by increasing the flow rate, reducing the net ultrafiltration, increasing the pre-filter and post-filter ratio, increasing the blood flow, reducing hematocrit. These are the technique can be used so that there will not be any coagulation. Because of this formula here, filtration fraction inversely dependent on the hematocrit. So it reduces the hematocrit, filtration fraction will be reduced. Okay, and also blood flow, total ultrafiltration rate should be, you have to reduce the ultrafiltration rate. Blood flow should be increased here to reduce the ultrafiltration rate. So in systemic anticoagulation, you can use either unfractionated heparin or low molecular heparin. Most in case of unfractionated, there is risk of HIT, heparin thrombocytopenia. Then you can use direct thrombin inhibitor like agratroban, bivalirudin, or 10A inhibitors like fondaparinux, danaparinux can be used in case of intermittent or continuous therapy. Most commonly used low molecular weight, usual first choice of intermittent therapies. Regional anticoagulation, as I mentioned here, citrate anticoagulation used, regional citrate anticoagulation for the intermittent therapies, not common practice. So when you use citrate, what happens? No, uh, uh, it will be using calcium for its action. So calcium is used here. This outflow will be more of calcium, less fluid will be there. You have to replace the calcium replacement fluid. So this you should know with when you are using regional citrate. When you are using hemodialysis, especially intermittent hemodialysis, there is a risk of hypotension is very high. So how to reduce hypotension means you can minimize the ultrafiltration. Instead of 2 liters, make it 1 liter or even 500 ml. Make a lot higher sessions you can seek, and also reduce the IV fluid, IV drugs, reduce IV fluids. This can be done. Okay, dialysis prescription, increase the session duration. Instead of 3 hours, make it 6 hours. Increase the frequency. It's 3 per week, move 4 or 5 per week. Optimize cardioactive exams, electrolytes like calcium and magnesium. Increase calcium means give some calcium, magnesium. Minimize osmolality shift like a sodium modeling. There should not be any sodium shift. That can be done. Pharmacology intervention, you some people use mannitol, but very rare. Albumin also used. Use Nordirland. Start with Nordirland before starting dialysis. Then when dialysis over, you can come down and stop, or even you can use oral midodrine. Disequilibrium syndrome is the one of the syndrome. It's a rarely and potentially fatal, a preventable complication of RRT. Here, what happens because of the sudden removal of solutes like urea and all osmotic gradient due to rapid removal of urea and osmotic solutes by RRT causes cerebral edema. This cerebral edema can cause seizures, coma, and all, drowsiness, very danger, complication. The syndrome is most reported in end-stage renal disease with advanced uremia who are initially started high frequency. Don't increase the frequency or dose high actually. Give a smaller dose here, like a KT by B ratio or URR ratio, or even you can use sessions also. Patient with end-stage renal disease should be treated with the adopted low frequency efficiency IHD. Management should be include rapid treatment with sedation means stop dialysis, give mannitol and hypertonic saline. Challenge is severe dyspnea. When there is hyponatremia is there, very careful because dialysis in there cause fluid shift and sodium shift can cause harmful. Go with the slow efficient dialysis there. And when to stop dialysis here, when there is a solute clearance 25 to 30 ml per minute during CRT will result in stable serum creatinine after 48 hours. If creatinine is normal after 48 hours or in output is there 500 ml per day, then we can stop and see whether patient really require dialysis or not. If there is output is improving, creatinine is coming down, then there is no dialysis. So renal replacement therapy delivered ICU are based on one or more combination same 3 basic principles like a diffusion, convection, and ultrafiltration. Timing, it is a more of conservative approach. If there is a life-threatening problem is there, go ahead. And if it is a no life-threatening problem, you can go for conservative approach and daily basis individualize the patient and go see whether the patient required dialysis or not. Modality, anything can use. If you have CRRT, in hypotension is a luxury, you can use it. If hypotension is there and there is no CRRT, you can go for prolonged intermittent therapy. So dose is KT bar V more than 1.2 and URR more than 7 is more adequate. Most of the time we won't achieve this dose. CRRT, as I mentioned, 25 to 30 ml per kg per hour is the dose. Thank you. If any doubts is there, I'm happy to answer. Any doubt? Unless you have to, um, um, tell the,
Hello. Hello.
sorry for that. There suddenly it is becoming, any doubt in this? Nesra is there. Shiva Shankar is there. Hello. Richard, any doubt?
No, sir.
Yes, sir. Okay, Richard, Shivshankar,
No, sir.
Samita.
No doubt, sir.
So it is clear? Is it clear concepts? Dr. Satish P is there, Jitin is there. See, it should be interactive. Then only you'll know where we are and what.
It's clear. It's clear.
It's clear. Okay. So now
Sir?
onwards in your ICU, please look into the dialysis. What technology they are doing, the dialysis or filtration or diafiltration. What is the dose they are using? Please look into this condition. So then you understand basic principles. Okay. And okay, your concepts are clear. Please share the PPT. Yes, I think it is recorded. It will be given to you. It is additional. These are the content classes they are giving. Additional who are not able to understand the module, they can attend even classes and try to attend and discuss. Should be interactive. So we are spending, we are giving some time for you people. Please utilize those time. Thank you one and all. Any questions is not there? Sundaram want to ask some question?
Sir. Can
Okay.
you hear me, sir?
Yes, please, Sundaram, please. Any question?
Yes, sir. Actually, 2 slides are for disequilibrium syndrome. For
Pardon?
disequilibrium syndrome, we have 2 slides, sir. In your PPT,
Yes. PPT?
the 2 slides follow disequilibrium syndrome, sir. Following disequilibrium syndrome, we had 2 slides which gave a guide where we have to go ahead with the RRP or we have to stop.
Yeah. Whenever disequilibrium syndrome is there, no? Disequilibrium is there. It's a case of when end stage
Yes,
renal
sir.
disease, higher dose is used. Means solute removal is more, shorter duration. What happens in brain? The moment you remove more and more solutes, but water is not coming out of the brain. There is a cerebral edema is happening. It's taking time to come out. That equilibrium is not happening in the brain. Solute versus water in the brain. What happens? Like what happens in hypernatremia? Hypernatremia causing, same thing happens in case of hyponatremia correction. Faster correction hyponatremia causes syndrome. Same thing here. There is a osmotic problem happening, causing cerebral edema, causes seizures, drowsiness, irritable, restlessness. In that case, stop dialysis. Okay, people are giving mannitol, albumin, and all. Better is stop dialysis, and yeah, you can try these 3% NaCl and osmotic, this one. But always try. Prevention is always try with a smaller dose in end stage renal disease with very high blood urea. Slowly come down. That's how we can do. Got it,
Okay, sir.
Sundaram?
Okay, sir. Wanted to know whether even without nephrology advice, we can stop dialysis now, sir.
Yes. In ICU,
Yes.
when there is a dialysis causing hypertension, when there is dialysis causing disequilibrium syndrome. See, if the dialysis hypertension, we have modalities.
Yes, sir. Yes, sir.
Increase, start with noradrenaline, increase the dose of noradrenaline, and see the temperature. If nothing is working, then stop it.
Yes, sir. Yes, sir.
Yes.
Thank you, sir. Thank you, sir.
If this class is working out better for you, if it is working out, then we'll continue further classes, because we want people to be interactive. Then only we can take classes. Shivshankar. Okay. Okay, then we'll close it. If any question you can put in the group, we are happy to answer there also. Huh? Okay, bye then.
Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.